Good morning, all. So happy to be back for a revision just before your exam. Okay. So I know you are in hot seat, waiting for the day to do excellent performance in your exam. So just I will just revise the most important areas which were covered in the last 2 3 years. Okay, so it will be like an MCQ pattern only discussion, but I will try to say, consolidate whatever thing is important. Okay, so I'll start as a question discussion. The first one, the thrombosis of pica, which artery is getting involved? So which artery is getting involved? The thrombosis of pica, this artery is getting involved. Which condition is associated? So many have selected A. Yes, exactly A. Okay. So this question actually is one important question because in lot of areas, okay, lot of areas in lot of ways, this question has been asked in lot of recent exams. Okay. So we know we have our vertebral artery and pica, okay, which is a branch, okay, and vertebral artery also has a branch, okay, uh, like this, and another branch called anterior spinal artery. So whenever this artery is getting involved, then we are going to have lateral medullary syndrome. Okay, so the differentiating point here, if you take the patient, there is going to be loss of pain and temperature over face and loss of pain and temperature over the body. So ipsilateral and contralateral. And one important thing in your question, okay, you have to notice here is there is no involvement of hemiparesis here. Okay, so whenever you see the word hemiparesis, you will not select it as lateral medullary syndrome. Whereas we have here anterior spinal artery syndrome. Okay, whenever there is a ASA, you have ipsilateral 12th nerve palsy, contralateral hemiparesis, contralateral vibration, position, proprioception loss. Okay, so that is going to be a medial medullary syndrome, and this one is going to be lateral medullary syndrome. And hope I'm clear here. This is very, very important. Okay, coming to your Weber syndrome. Okay, so if it is going to be Weber syndrome, then it is a midbrain syndrome. Okay, midbrain syndrome. In midbrain syndrome, we have Weber syndrome, Claudy syndrome, Benedict syndrome. So Weber is ipsilateral third nerve palsy. So whenever it is a third nerve palsy, the patient is going to have a down and out eye, okay, plus contralateral hemiparesis. Contralateral hemiparesis, that is very, very important. Whereas if you come to Claudy, Claudy is ipsilateral third nerve plus the patient is going to have contralateral tremors and contralateral ataxia. Okay, and Benedict's is a combination of Weber's plus Claudy. Okay, Weber's plus Claudy. Okay, and this is about your uh, midbrain. Okay, and whenever your midbrain is getting involved, the artery which is getting involved, okay, the artery which is concerned, okay, the artery which we have to think about, okay, is going to be our posterior cerebral artery. Posterior cerebral artery, that is very, very important thing. Okay, very, very important thing, posterior cerebral artery. Okay, so this is an important thing for your exam. Okay, so we are left over with Pons. In Pons, there are two important things we have to think about. One is Millet-Gubler syndrome. The second one is Raman syndrome and Fovili syndrome. So what is the difference between these two conditions actually? For exam, what is important you have to consider? In this two condition, it is sixth nerve palsy. So because of the sixth nerve palsy, you are going to have lateral rectus palsy. Lateral rectus palsy. Whereas in Fowling syndrome, it is going to involve MLF and PPRF ipsilaterally. So because of this, there is going to be affection of lateral gaze palsy, not lateral rectus palsy. It is lateral gaze palsy. Because of lateral gaze palsy, you are going to have horizontal gaze palsy. Horizontal gaze palsy. So that is very, very important here. Okay. So that is going to grossly differentiate these two conditions. Apart from this, you know, it is MGS, Millet-Guebler syndrome is 6th plus 7th nerve. Okay. Whereas Raymond is only 6th nerve. That is also again an important point to think about. Okay. So these are few important highlights which you are going to see in your question, which is going to give you a clue about your uh, answer. Okay, so with this, the first question is over. We'll come to the second question. Patient presents with frequent urination, nocturia, and enuresis. Okay, so that is one thing you are noting in this patient. Okay, and this patient is having a 24-hour urine volume which was measured and recorded to be 7 liters. The urine osmolarity is 260 milliosmoles per liter. ADH assay was performed and it was 0.8 picogram per ml, and MRI of the brain was performed. Absence of bright spot is seen. What is the most likely diagnosis of this patient condition? So many have gone for pituitary DI. Okay, so the answer is also pituitary diabetes insipidus. Okay, it's very good, excellent. Okay, so why this is pituitary ADI? Okay, so pituitary diabetes insipidus. Okay, so the clue in the question, okay, the clue in the question is the patient is have frequent urination. Okay, and the urine volume is more than 7 liters, indicating that the patient is having polyuria. First important point. Okay, so polyuria. The second important point is the patient. Okay, the patient has low urine osmolarity. Okay, that is less than 280 is present. Okay, it means that the urine is a dilute urine. Okay, and you can see the ADH level that is also looks low. Okay, so the patient has a low ADH level. Okay, then next is absent bright spot. So that is one important clue which gives an obvious idea about your central diabetes insipidus. Okay, so whenever the urine osmolarity is low, it is understood that the serum osmolarity is high. The serum osmolarity is high. Okay, so how to go about in this patient? Okay, so whenever you have any question, okay, whenever you have any question related to your diabetes insipidus or polyuria, so what you are going to do? Okay, so whenever the question is about polyuria, okay, you always check for urine osmolarity. Okay, the urine osmolarity in this condition will be low. Okay, so usually it is less than 300 up to 280. Okay, so it is less. The next step is going to be plasma ADH, as I told you previously. Okay, so you check for ADH whether it is more than 1 picogram per ml or less than 1 picogram per ml. Okay, whenever it is more than 1 picogram per ml, it means that there is enough production of ADH, but this ADH is not acting. Okay, it is not acting at the target. So whenever it is not acting at the target, it is going to be nephrogenic diabetes insipidus. Okay, whenever the level is low, then the next step is you do a MRI brain. Okay, MRI brain. Okay, whenever you do a MRI brain, the first thing what you're going to see is if this is the pituitary gland, You see, this is anterior pituitary in posterior pituitary. Because of the posterior pituitary having lipid content, it is usually a bright spot. Okay, whenever the bright spot is present, okay, it means there is a normal pituitary gland. Okay, and this pituitary gland produces enough ADH, but it is not going to act in a proper way due to some reason. Okay, so that is going to be primary polydipsia, or it is also called as psychogenic polydipsia. Okay, whereas whenever you have the posterior pituitary bright spot absent, okay, then it means that there is no ADH is getting secreted. Okay, whenever there is no ADH getting secreted, then you are going to think it as central diabetes insipidus. Okay, central diabetes insipidus. Here, one more thing. Yeah, I have put here. Okay, normal ADH. Okay, so one more point I can put here. Okay, one more point is put here. A patient with these symptoms, okay, these symptoms is going for water deprivation test. Okay, out of these three options, okay, out of these three fellows, who will respond to water deprivation test? Who will respond to water deprivation test? So water deprivation test is 8 hours you don't give water to the patient. So if he is responding, then it is going to be psychogenic. Who will here respond to intranasal desmopressin? Out of these three fellows, who will respond to intranasal desmopressin? It is central diabetes insipidus. No response to desmopressin. Okay, both the things, then it's going to be nephrogenic diabetes insipidus. Okay, so this is also one thing which can be added in your question. Okay, so whenever you know this, then you can answer the question easily. Okay, then you can answer the question easily. Okay, so this is very, very important. Okay, very, very important. And one more thing which I can add here, which diuretic can be used as a treatment in patients with diabetes insipidus, which has an effect by acting uh, reabsorption in PCT. Okay, so it is thiazide. Okay, thiazide. Okay, so this thiazide usually acts at the convoluted distal tubule, and it has an indirect effect by reabsorbing water in the PCT, thereby it decreases, okay, the effect of diabetes insipidus. Okay, so that is thiazide diuretics. Okay, thiazide diuretics, very, very important thing. Okay, so this is about your diabetes insipidus. Okay, okay. Next question: what levels of prolactin indicates that prolactinoma? So many have gone for D answer. Okay, we'll see. So if you take the prolactin, the normal prolactin level is less than 25. Okay, whenever the prolactin level is increased and it is somewhere around 50s, okay, then it is going to be physiological. Physiological. So where you can get physiological? Whenever you have um, uh, pregnancy, nipple stimulation, post-delivery lactation. In all these reasons, even in stillbirths, you can have prolactin being slightly raised. Okay, whenever you consider this prolactin, okay, prolactin, this prolactin is stimulated by dopamine inhibiting or controlled by dopamine inhibiting factor, which inhibits this prolactin production. Okay, so whenever someone inhibits this dopamine, okay, what is going to happen? The prolactin level is going to increase. Okay, for that reason, all dopa depleters, all dopa antagonists will increase the prolactin level up to 100. But whenever the patient has a prolactinoma, more than 200, to 400, it indicates the patient is having prolactinoma. This prolactinoma can be further classified into two types. Whenever the size is less than 10 millimeter, more than 10 millimeter, it is going to be microadenoma. Whenever it is more than 10 millimeter, it is macroadenoma. Okay, so whenever it is a microadenoma, it is small in size. So whenever it is small in size, it has more of hormonal effects. Hormonal effects. Whenever it is macroadenoma, more than hormonal effects, it has compressive effects. Compressive effects. So whenever it is a hormonal effect, it is going to be characterized by a triad. Okay, triad, or it can be having a constellation of symptoms. Okay, the constellation of symptoms is going to be, okay, the constellation of symptoms is going to be, the patient is going to have lactation or milk production, infertility, osteoporosis. Okay, so here I just thought of asking one question. Okay, so whenever it is a I was thinking, okay, so whenever it is a macroadenoma, okay, macroadenoma, okay, what kind of clue will be given in your question? If they want to give you a clue, what clue you will expect in this question? Very good. You are going to have bitemporal hemianopia. Bitemporal hemianopia. Okay. So here I want to again add one thing. Okay. If you take the optic chiasma, the optic chiasma is like this, and here we are going to have our pituitary gland, okay, which enlarges like this. Okay. At the same time, there is one more tumor which is here. Okay. So this tumor is going to be a cellular tumor, whereas this one is a supracellular tumor. Okay. Whenever it is a cellular tumor, it will cause, okay, bitemporal hemianopia, but it is going to cause superior bitemporal hemianopia, whereas this one is going to cause inferior bitemporal hemianopia. Okay, so what is the thing? Okay, OP is osteoporosis. So this is going to be your craniopharyngioma. This is going to be your craniopharyngioma. This is going to be a craniopharyngioma. The next question what they can ask you here is, what is the treatment? What is the first line treatment? First line treatment. It is going to be dopa agonist. Here we have two options. One is bromocriptine, another one is cabergoline. Out of this, what is the drug of choice? Drug of choice is cabergoline, whereas bromocriptine is drug of choice in pregnancy. Okay, here there is again they are going to put one twist here. Okay, twist here. Okay, if it is going to be a growth hormone adenoma, what is the first treatment of choice? Growth hormone adenoma, what is the first treatment of choice? The first treatment of choice in growth hormone adenoma is surgery. Surgery, always remember this. Okay, so even though we can give somatostatin analogs, but here the drug treatment of choice, the first treatment of choice is surgery, whereas here the first treatment of choice is medical treatment. Okay, medical treatment, that one is very important thing. Okay, that is very important thing to differentiate. Okay, very important thing to differentiate. Okay, so this is about your prolactinoma. Okay, prolactinoma. Coming to the next question, what is the most common extra-articular manifestation of rheumatoid arthritis? Somatostatinoma. question. Okay, I will discuss it. You can message me. Okay, I will discuss that. Okay, so you are going to go for subcutaneous nodules. Okay, subcutaneous nodules. Okay, so that is going to be the correct answer here. So whenever a patient comes to you, okay, and that patient is having rheumatoid arthritis, okay, rheumatoid arthritis, okay, the most common extra articular manifestation is going to be subcutaneous nodules. The most common extra articular organ, okay, is going to be, they say, lymph nodes. Okay, the most common organ to be considered, two things. One is lung, another is eye. In eye, we get to see two features: episcleritis, scleritis. Okay, scleritis, lymph node, lymph node. Okay, in episcleritis, we get to see a feature called as scleromalacia perforans. Whereas in scleritis is the most specific feature. Okay, coming to lung. Okay, lung. In lung, okay, what is the feature you get to see in lung? Okay, so lung you get to see ILD, and in ILD you get to see usual interstitial pneumonia, and very excellent, Dr. Varsha, and you have a pleural effusion which have a very low glucose pleural effusion. So it is usually less than 45. Okay, less than 45. Okay, so usually whenever you have a very low glucose, okay, you have three differential diagnoses. One is going to be infection, pneumonia, etc., tumor, and rheumatoid arthritis. In both these conditions, it will be okay. So here it is infection, tumor. So here it is going to be less than 60. Okay, so here it is very low, it is less than 45, they say. Okay, so that is very important thing to note here. Okay, very important thing to note here. So coming to the next important thing, which is going to be your subcutaneous nodules. Okay, so whenever you have a subcutaneous nodule, it is considered as benign, non-tender, okay, seen over extensor surface, okay, extensor surface, okay, and these patients, okay, have high correlation with two things: disease activity and RA factor and CCP. Okay, whenever there is a subcutaneous nodules, okay, subcutaneous nodules, you have to think about one condition which is going to be called as Felty syndrome. What is Felty syndrome? It is characterized by splenomegaly. Then it is characterized by anemia, neutropenia, thrombocytopenia, and patient is going to have rheumatoid arthritis. Okay, along with this, they can have rheumatoid nodules also. Okay, they can have rheumatoid nodules also. That is Felty syndrome. Okay, Felty syndrome. Very important thing for your exam. Okay, so these are few highlights about your rheumatoid arthritis. Okay, few highlights about your rheumatoid arthritis. Okay, then coming to the next question. Periodic acid stiff positive macrophages are seen in fast positive macrophages. So many have gone for Whipple's disease. Okay, many have gone for Whipple's disease. Okay, Whipple's disease. Okay, very important. Okay, so Whipple's disease. Okay, so whenever you see in your question fast positive macrophages, okay, then it is going to be Whipple's disease caused by Proforima whippleyi. Okay, so if you see here, this is an this is an biopsy specimen where you can see this pink color. Okay, this pink color along with violet color. Okay, whenever you get this pink color with violet color, okay, then they are pass positive materials. Okay, pass positive macrophages. Okay, pass positive macrophages. So what is the triad of this condition? So in your question, what you expect, what you want to see? Okay, so whenever they give you chronic diarrhea, okay, with fever, arthralgia. Okay, this is again the fever is PO, piles of unknown origin, long-standing fever. Okay, arthralgia with sometimes the clue is given as neuro manifestation. Neuro manifestation, that is involving either psychosis, hypothalamus, okay, any hypothalamic changes, okay, or ophthalmoplegia. Okay, any clue about neurological involvement or cardiological involvement like endocarditis, heart failure. Okay, then think about Whipple's disease. Okay, it's not only about diarrhea. Okay, so what is the investigation you will do in this case? Whenever you plan for investigation, you will go for intestinal biopsy. So this is one condition which is biopsy specific condition where they are going to be pass positive diastase enzyme resistant. Okay, diastase enzyme resistant. Okay, inclusions in lamnia propria, lamnia propria, lamnia propria. But whenever you want to go for a better specific investigation, then go for PCR. Okay, and you can also go for urine PCR on follow and follow. Okay, so here it is very important thing. Okay, so biopsy, even though you do, okay, biopsy specific condition is a Whipple's disease, but biopsy is not the investigation of choice. We have to go for PCR. Okay, and then follow up you have to go for urine PCR. Okay, and one more thing which is very important here is treatment. Okay, so here you go for ceftriaxone or you go for meropenem. Okay, and it is given for 2 to 4 weeks, followed by doxy or minocycline or hydroxychloroquine. Okay, which is given for 1 year. 1 year you have to give doxy, minocycline or hydroxychloroquine. Previously they were giving Septran, but the problem with Septran is it had a high relapse rate. So they are not giving it. Okay, nowadays you go for prophylaxis or follow up with doxy, minocycline or hydroxychloroquine for a period of around 1 year you are going to give. Okay, so that is very important thing about your very important thing about your Proforma Whipple. Okay, so that is very important. Very good. Okay, so whenever you have this, then it is very specific to go for PCR. That is very important thing. Okay, so with this we finish and go to the next question. Again, this is an easy question, but I don't know, for a lot of reasons they're asking these questions repeatedly. Psychosis. Okay, you can take it as psychosis. So which of the following, according to Merlin definition, is moderate ARDS is characterized by except? Okay, it's a very easy question. Okay, but a question which has to be think about, because lot of times the ARDS being a medical emergency, they ask in NEET exam. Okay, so medical emergencies you should be very careful and very sure. Okay, for example, you have to be very sure about PSVT. Okay, PSVT, if possible we'll have one more discussion, if possible we'll have on these emergencies, which is very important. One is PSVT. Okay, then they can ask you about foreign body okay, foreign body. Then third is VT, okay, VT. Then next is HOCM, sudden cardiac death, okay, sudden cardiac death. Okay, so these are few areas. If you take even uh, in cardiac emergencies or overall emergencies, these are few things which are important. Next is you can consider pneumothorax, okay, pneumothorax. Okay, foreign body usually in child it is very very important. Child they will ask. Okay, so these are few areas which are very very important for your exam. Repeatedly one question will come from this part. Okay, and another thing is IV fluid management also sometimes they used to ask questions. Okay, IV fluid management also they are going to ask you question. Okay, so whenever you have a patient coming to you with ARDS, the ARDS is going to be acute in onset, less than 1 week. Next is you're going to calculate the ratio, which is going to be PaO2 by FiO2 ratio. Whenever it is less than 300, it is mild, less than 200, moderate, less than 100, severe. Okay, IVF is IV fluids. Okay, then D for the patient has diffuse infiltration in chest X-ray. Okay, then you put a Swan-Ganz catheter and it shows a non-cardiogenic pulmonary edema, which is going to be a PCWP, pulmonary capillary wedge pressure, less than 18. Okay, less than 18. It is non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema. Okay, so this is very very important thing to note in your patients. Okay, note in your patients. Okay, and with this you are going to have a patient coming to you with ARDS. Okay, so in ARDS, even in my class, in our class we would have discussed, it is a exudative condition. One thing which is very very important. So whenever there is a exudative means it has a high protein exudate. High protein exudate. Okay, and the most common cause is sepsis, and this sepsis leads to death. The next important thing here is going to be you are going to have mechanical ventilation as a treatment. Mechanical ventilation, and whenever you do mechanical ventilation you have to go for a low tidal volume ventilation. Okay, which is going to be 4 to 6 ml per kg. 4 to 6 ml per kg. Okay, so this is going to be very very important. Okay, 4 to 6 ml per kg, low tidal volume. Okay, so this is very 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 important. Okay, so this is about your ARDS and nothing more than that. This they are going to ask in ARDS. Okay, so that is very very important. This is very very important. Okay, coming to the next question, what should be the answer? You are going to go for ANCA. Okay, so all these features tell that it is a vasculitis. Okay, vasculitis. So whenever you take vasculitis, it can be a primary vasculitis or a secondary vasculitis. The most common association with secondary vasculitis is going to be your rheumatoid arthritis. Okay, rheumatoid. A lot of conditions are there. Rheumatoid arthritis is very very important. The one more classification of vasculitis is going to be one large vessel vasculitis, medium vessel vasculitis, small vessel vasculitis. Okay, so here they can ask you the first one is granulomatous vasculitis. Granulomatous, if they give a question, okay, then you have to think about two things. Okay, one is giant cell arteritis, Takayasu arteritis. Okay, and the second one is vaginous granulomatosis, Church-Strauss syndrome. Okay, it means that here the non-granulomatous condition, since I'm telling about small vessel vasculitis here, you think about microscopic polyangiitis. Okay, the second way is immune complex deposition or immune complex mediated. Okay, in immune complex mediated, there are two important conditions. one is going to be your Schonen purpura. Okay, so since I'm using these small abbreviations because it's understood. Okay, HSP and essential mixed cryoglobulinemia. Okay, so whenever you have HSP, in HSP it is going to be IgA. Okay, and essential mixed cryoglobulinemia it is going to be IgG and M. Okay, IgG and M. Okay, then next is you can classify it as ANCA associated vasculitis. In ANCA associated vasculitis, we have two options, whether it is a P ANCA or C ANCA. Okay, so you all know that C ANCA means it is vaginous granulomatosis. P ANCA means it is going to be two conditions. One is going to be Church-Strauss syndrome. The other one is going to be microscopic polyangiitis. Okay, whenever you have C ANCA, P ANCA, okay, these are antibodies. These antibodies are produced against the proteinase 3. Okay, whereas P ANCA is produced against myeloperoxidase. Okay, myeloperoxidase. So how to identify this? You're going to go for immunofluorescence. Immunofluorescence in P ANCA will show a pattern like this. Okay, whereas C ANCA will show a pattern like this. Understood? So these are grossly the difference between different kinds of vasculitis. Whenever it is a small vessel vasculitis, okay, whenever it is a small vessel vasculitis, it involves arterioles, capillaries, venules. Okay, so whenever it is involving these three areas, wherever you get these three areas, it is going to involve. Okay, so where are these areas? Pulmonary. Whenever it involves the pulmonary vessels, patient is going to have hemoptysis. Okay, hemoptysis. Whenever it is involving the glomerulus, glomerular capillaries, glomerulonephritis. Because of glomerulonephritis, patient will have hematuria. So whenever this combo is given, then think about small vessel vasculitis. And for small vessel vasculitis, you are going to go for diagnosis with ANCA. Okay, and one more thing is peripheral neuropathy. And if it is going to be a peripheral neuropathy, it is going to be mononeuritis multiplexa. Mononeuritis multiplexa. Okay, so these are few features which tell that it is a small vessel vasculitis. Okay, small vessel vasculitis. Okay, so we will go into the next question. Myasthenia gravis is associated with. Easy question, but slightly tricky. Okay, so I have seen a lot of people usually select for this one. Okay, but this is not the answer. The answer is decreased synaptic transmission at the myoneural junction. Okay, that is the answer. Okay, so if you take a myoneural junction, okay, myoneural junction. So this is the myoneural junction. Okay, in myoneural junction, we have two types of channel. PQ type of calcium channel, where we have fast channel, slow channel. So from here, what happens during stimulation, acetylcholine will get released. Acetylcholine will come and released, and this acetylcholine will come and bind to the receptor here. Okay, whenever you have acetylcholine receptor antibodies, what is going to happen? There is a block here. Okay, so because of this, what is going to happen is the patient muscle is not going to be active after some times. So the first thing is there is going to be diurnal variation. Diurnal variation. the patient is going to have asymmetrical ptosis and ophthalmoplegia. Okay, asymmetrical ptosis, ophthalmoplegia. They are going to have, okay, they are going to have one more thing, which is going to be dysphagia and choking. They are going to have proximal muscle weakness. Okay, so all these things point towards the patient having myasthenia gravis. So they are going to, you are going to check for anti-acetylcholine receptor antibody, and this is seen in 85% of cases with thymic hyperplasia and 15% to 10% of cases with thymoma. Okay, somewhere around this one. And one more thing is, it is seen in 85% of cases with generalized myasthenia gravis, okay, and around 50% of cases with ocular myasthenia gravis, okay. Apart from this, we have another one antibody called as anti-musk antibody. We have other antibodies also, but here this is important, okay. So this can be positive in patients who are acetylcholine receptor antibody negative, okay. So here, very important, DD is Lambert-Eaton myasthenic syndrome, where there is no diurnal variation, okay, and it is presynaptic antibodies, whereas our myasthenia gravis is postsynaptic, okay. And the drug of choice here, okay, or the drug which can be given here is going to be 3,4 diaminopyridine, okay, whereas the treatment of choice in myasthenia gravis is going to be stigmine. So if it is 60 to 120 mg 4 times per day, it is given. Okay, so these are few important things about your patient coming to you with myasthenia gravis you have to consider and treat investigation. Okay, we have two types here. Also, there will be a lot of confusion every time. Screening test is going to be antibodies, and confirmatory test we have to go for single fiber EMG. Okay, and in between we don't have investigation of choice. Repetitive nerve stimulation test, okay, then repetitive nerve stimulation test and hydrophonium test. All these are tests done but not confirmatory. Okay, thymectomy. If you take the thymus gland, inside thymus gland there is one cell called myoid cells. The myoid cells are similar to our acetylcholine receptors. Okay, for that reason, the antibody which are produced against the myoid cells will target the acetylcholine receptors. Okay, and you can go for prophylactic thymectomy in patients who have an age group of 15 to 55 years. Okay, who are going to be anti-musk negative and good vital capacity of lung. Okay, in those patients you can go for thymectomy. Okay, thymectomy. So this is about your patients coming to you with problem with muscle stimulation due to difficulty in having acetylcholine receptor conduction. Okay, so next question we come here. Good vital capacity, lung function. Okay, lung function test is normal. So answer here is, here many have gone for sickle cell anemia. Okay, sickle cell anemia. Okay, so we will try to rule out the options here. Okay, why we have to rule out the options, we'll see here. Okay, here I will go for. Okay, so why we have to rule out the options. Okay, so here a patient comes to you with multiple episodes of acute pain in fingers and toes, that is peripheries, which resolves on its own. Okay, that is the only thing which I have given, and a young boy is coming. Okay, so what is the thing you have to consider? Okay, so if you take option A and B, alpha thalassemia, right? Alpha thalassemia, beta thalassemia. These two options are there. Okay, whenever you have these two options, there are going to be hemolysis, and because of the hemolysis, the patient is going to have pallor, jaundice, hepatosplenomegaly, repeated blood transfusion, okay, and patient will have thalassemic phases. Okay, and if you take a X-ray, hair on end appearance, okay, nothing has been given in the question, so option A, option B ruled out. Coming to option D, okay, why we are ruling out option D, von Willebrand disease. Whenever you have von Willebrand disease, they have to give mucosal bleeding. Mucosal bleeding. They have not given anything about mucosal bleeding. Okay, so mucosal bleeding means patient can have epistaxis, bruises. Okay, nothing has been given. So leftover option is C. Leftover option is C, which is going to be sickle cell disease. Okay, so whenever you have the smaller venules, this is a small blood vessel. Okay, whenever the vessels has decreased blood flow because of the cells becoming like this. Okay, they are going to go for vaso-occlusion. Vaso-occlusion. Okay, vaso-occlusion. Okay, whenever there is a vaso-occlusion, the patient will have pain over the fingers and toes, and that is called as dactylitis. Dactylitis. Okay, dactylitis. Okay, so dactylitis is one thing which is going to cause severe pain over the bones of the hands and feet. Okay, and sometimes it can be the first manifestation of your patient with sickle cell disease. Okay, for that reason, it is very, very important. And for this, what you have to go for is you have to go for opioid analgesia. Okay, opioid analgesia has a pain relief here. Okay, analgesia will have a pain relief here, and it is going to be very, very important. Okay, and it is also one which prevents death due to arrhythmias and pulmonary embolism. Okay, apart from this, okay, what is going to happen, there can be acute splenic sequestration. Okay, because of that the patient might require emergency splenectomy. Then splenic autoinfarctions can occur, CVA can occur. Okay, in kidney, what can happen? In kidney, what can happen? It is known to cause renal papillary necrosis. So because of this, what is going to happen is the concentrating ability of the kidney is lost, and because of this, the patient can develop isothenuria. Isothenuria. Okay, isothenuria. Okay, so it is a specific gravity is constant. Okay, constant. There is no variation in specific gravity. Isothenuria can occur. Okay, so these are a few things about your patient having vaso-occlusive crisis due to sickle cell disease. Okay, coming to this question, answer you're going for. So everyone goes for serum ceruloplasmin level. Okay, so everyone is going for serum ceruloplasmin level. Okay, so okay, that is the most correct answer. Okay, most correct answer. Okay, since many of you have selected, that is the most correct answer. Okay, so what are the factors which are given in this question which are going to tell you a diagnosis? Okay, so whenever you have a child, okay, so somewhere around, for example, 10 to 40 years, a person is coming, okay, with hepatitis, liver, okay, then the neurological involvement because of the striatum involvement, okay, and because of this there is going to be hepatolenticular degeneration is involved. Okay, hepatolenticular involvement is there. Okay, I shows kf ring. Kf ring presence has high correlation with neuro manifestations. Okay, so it tells that this is a case of Wilson's disease. Okay, this is a case of Wilson's disease. Whenever Wilson's disease is there, what you're going to do? Okay, what you're going to do? Okay, so the first step is what happens here is there is going to be ATP 7B gene mutation. Okay, so what because of this there is going to be increase in copper. Usually copper goes and binds to, okay, ceruloplasmin. Ceruloplasmin. Now, because more amount of copper goes and binds to this ceruloplasmin, what happens? The ceruloplasmin level in the body will become low. Okay, so this low ceruloplasmin level can be used as the initial screening test. Okay, screening test. Okay, okay, screening test. Okay, so because of this, the bound copper decreases, free copper increases. Okay, whenever this free copper increases, the excess copper will get excreted in urine. So what is going to happen? The urinary copper increases. Okay, this increases. Okay, then since the copper is binding to ceruloplasmin, there will be low bound copper. So because of this, there is going to be the total serum copper will be low. Okay, low. Whenever there is more amount of free copper, what happens? This copper will go and deposit over the tissues. Okay, so because of this, what is going to happen? The hepatic copper will be more. Okay, it is more than 200 microgram per gram dry weight of liver. Okay, and this is the gold standard investigation. Gold standard investigation. Okay, it is a gold standard investigation. Okay, gold standard investigation. Okay, so this is about here for different things. So here, if you take here, if ceruloplasmin level is the correct option. Okay, as investigation of choice for screening. Okay, serum copper level. Okay, serum copper level. Okay, so total serum copper level, even though it is decreased, it is not useful. Okay, not useful. Enzyme assay. Okay, enzyme assay, it is used in neonatal screening but not as the screening test. Okay, neonatal screening but not in the adults. Okay, karyotyping. Okay, karyotyping is usually, okay, done in asymptomatic first degree relatives. So it is used as a test to early identification, but not in a patient who is already having the disease. Okay, for that reason, again, we are going to rule out that option. So we have ruled out. Okay, so if you take a drug of choice, okay, drug of choice, serum copper is a total serum copper. Okay, serum copper is a total serum copper. It is not going to be more specific. Okay, it is not specific actually. Rather, if you go for ceruloplasmin level, it will give more clear idea. Okay, for that reason, you go for this thing. Okay, so drug of choice. Okay, so drug of choice. Previously, they were using D-penicillamine. Okay, now they are going to combine it with trientine. Okay, trientine. Okay, then you are also going to go for zinc. Okay, whenever there is neuro manifestation, you go for tetrathiomolybdate. Tetrathiomolybdate. Okay, so this is very important thing. Okay, very important thing. So here there are a lot of ifs and buts are there, but towards the exam time, this is more than enough, I think. So that ifs and buts are will confuse. Okay, for the ifs and buts, we'll stop the ifs and buts and we'll go for this. Okay, now coming to the next question. So a lot of people have gone for D. Very good. D. Okay. So if you come here and see, whenever a patient has high chances of sudden cardiac death, okay, sudden cardiac death, okay, so okay, here, okay, you are going to go for automatic implantable cardioverter or defibrillator. Okay, defibrillator. So what this defibrillator is going to do? Okay, defibrillator to do. What it will do is it will detect arrhythmias. Okay, it will detect arrhythmias and it is going to perform cardioversion. Okay, cardioversion. Okay, now here what is the indication? Okay, what is the indication? Okay, first is Brugada syndrome. So you all know that Brugada syndrome is a channelopathy due to sodium channel SCN4A, okay, which can cause sudden cardiac death due to arrhythmias. Okay, then next is ventricular fibrillation. A patient with ventricular fibrillation or VTAC can anytime can develop sudden cardiac death. Next is patient with ACS, acute coronary syndrome. Okay, in acute coronary syndrome, okay, a patient who has low ejection fraction can develop arrhythmias at any time. Okay, arrhythmias at any time. Okay, so whenever a patient is coming to you with acute coronary syndrome and history of recent MI of more than 40 days, in those patients, what you're going to see is you're going to see for NIHA classification. Okay, NIHA heart failure. Whenever they belong to class 2, 3, okay, with a LVF of less than 35%, class 1 with the LVF ejection fraction of less than 30%, then you prefer ICD. Okay, then you prefer ICD. These are three important indications. Okay, indications for ICD. Okay, three important indications for ICD. Okay, Brugada syndrome, ventricular fibrillation VTAC, and ACS with low ejection fraction. And the MI should be a recent onset MI of more than 40 days old with the heart failure. Okay, so this is very important. And these kind of questions are again being asked in exam. Okay, so before finishing, we'll go for this last question if you want. Okay, with this as we can keep it as last question. Okay. Okay, so they have asked about pseudo P pulmonale. Okay, pseudo P pulmonale. Okay, so what is pseudo P pulmonale? Okay, whenever you have a P wave which is taller than 2.5 millimeter, then you will get in P pulmonale. Usually, whenever you have a P pulmonale, okay, P pulmonale, it indicates that patient is having cor pulmonale. Whenever the boxes, okay, crosses more than 2.5 millimeter like this, then it is going to be seen in P mitral, which indicates mitral stenosis. Sometimes you get a tall peaked P wave like this, and this P wave can be seen in patients with hypokalemia. Hypokalemia. Okay, so answer is going to be hypokalemia. Okay, answer is hypokalemia. Okay, so what are the features you get to see in hypokalemia patients? Okay, hypokalemia patients. Okay, so whenever a patient has potassium more than 3.5, then it is going to be normal. Okay. Now a patient comes to you with potassium, for example, less than 3. Okay. When it is less than 3, you get a flat T wave. That is the earliest change you get to see in patients. Okay. Then whenever it is somewhere around 2 to 3, okay, 2 to 2.5 or 2 to 3, you get to see U wave. You get to see U wave. Okay. And along with U wave, you get to see STT flattening. Okay. And followed by, you can also get a pseudo P pulmonale. Okay. Whenever it is less than 2, okay, it results in ST depression. Okay, ST depression. Okay, ST depression. Okay, and the U wave amplitude increases. The U wave amplitude increases. So normally, whenever you get an ECG, usually whenever it is hypokalemia, what happens? This is the normal ECG, for example. Now what happens? They get a like this. So this indicates U wave. This indicates P pulmonale. And ultimately, this area goes for flattening. After some time, like this, flattening. Okay, flattening. Okay, and one more important thing here is whenever you have sodium, there is no much of ECG changes. Okay, much of ECG changes. And if you have hyperkalemia, what happens in hyperkalemia? What happens in hyperkalemia? You imagine you are holding the ECG at this 2 point. Okay, you stretch the ECG. You stretch the ECG like this. When you stretch the ECG, what is going to happen? There is going to be prolonged P wave, PR interval, shortening of QRS. Okay, to compensate this, we are going to have a tall T wave, a tall T wave. Okay, and this tall T wave will be a tented T wave. Okay, and it will be symmetrical, tented, symmetrical. Okay, whereas the tall T wave, okay, is symmetrical. Okay, so this is very, very important. Okay, very, very important. Then coming to calcium. Why calcium is required by the heart muscle? Calcium is required for contraction. Which contraction? Ventricular contraction. Okay, so whenever you have a low calcium, hypocalcemia, what happens to the heart contraction? The heart contraction is slowed. The heart contraction is slowed means it means ventricular contraction is slowed. Okay, which part of your ECG represents ventricular contraction? QT. Okay, so there is going to be QT prolongation. Okay, whereas whenever you have hypercalcemia, there is going to be QT shortening. QT shortening. Okay, so this is very, very important to note in patients with your ECG changes with relation to electrolytes. Okay, ECG changes with relation to electrolytes. Okay, electrolytes. So we have seen few questions here. Okay, so almost some questions which are very, very important. Okay, very, very important. And since it's a revision thing, okay, so I'm not going to take much of your time. Okay, much of your time. I just want to just revise and finish the topic. Okay, for that reason, I'm finishing here. But before finishing, one more question I will discuss, which is very, very importantly asked every time in your exams also. For that reason, I will do that also. Okay, this one. This one. This one. You tell me answer for this one. Answer is remote infection of hepatitis B. Okay, so remote infection of hepatitis C. So whenever I tell about hepatitis C, okay, so I want to you people to remember certain things. Okay, so this is the second virus. Okay, second virus. So you remember about the second virus. Okay, second virus. Okay, so if you take the second virus, the second virus is a DNA virus. DNA virus. Okay, so here we have a surface antigen which we call it as HBsAg. Okay, we have a envelope. So we have a HBsE antigen. Okay, hepatitis E antigen. Then we have HBC antigen, but this hepatitis B C antigen is not readily visible. Readily visible. Okay, readily visible. Okay, so this second antigen, okay, or second virus has antibodies produced against this. Okay, antibodies produced against this. Okay, so whenever you are having antibodies produced against this, okay, it is going to be anti-HBs AG. Okay, it is going to be anti-HBs AG. Okay, anti-HBs AG. Okay, now whenever you have an anti-HBs AG here, okay, you have anti-HBe AG. Okay, then next is anti-HBc AG. This anti-HBc AG is of two types, IgM and IgG. Okay, once the virus enters into the body, the patient is going to be having HBsAg positive. Okay, so viral entry and presence. Okay, whenever this viral entry and presence is there, obviously after some time you have antibodies. So it indicates past infection, or you have given the virus not because of infection, but outside the infection you have given. So it indicates vaccination. This envelope is the one which tells about the multiplication of the virus. Okay, lot of envelopes are produced. Okay, so this indicates that viral replication. Okay, viral replication, and this viral replication is a qualitative marker. And HBC antigen is inside the core. Okay, it is protected inside the envelope, so it is not usually visible. Okay, whereas if you take this one is seen in certain conditions. Again, this is not important. So if you come here, you have a anti-HBC antigen, okay, against which the antibodies are produced, and this indicates that it is a acute infection. This indicates that this is a chronic infection, okay, or past infection. Okay, now whenever you have IgM, okay, it is the only antibody which can be present in the window period. So there also it is very, very important. There also it is very, very important. Okay, so these are few things which you have to remember. Now your patient has HBsAg non-reactive. Okay, HBAg non-reactive. IgG, okay, is positive. Okay, and IgM is negative. So what it indicates? The patient has no acute hepatitis B. Okay, no acute hepatitis B. He has a past hepatitis B infection. Okay, so which antibody other than this you will expect here? Which antibody other than this you will expect here positive? Which is not given in this question. Which antibody you will expect positive? So you will expect here anti-HBsAg also. Okay, whenever you have a HBsAg, okay, it is active infection. It can be acutely active or chronically active. Okay, so this is very, very important. Okay, and it is IgG HBs C antigen positive. Okay, so this is about your this thing. Okay, this is about your this thing, and it's very important thing. Okay, very important thing. So this is about our hepatitis B infection, which is very important thing for your exam. Okay, very important thing for your exam. So hepatitis B, without studying, don't go for exam. Okay, so for that reason, you read about the hepatitis B treatment serology and hepatitis C treatment. Okay, very important. Okay, so this is about your thing. Okay, so the last few things about before going for exam. Okay, last few things before going for exam. Okay, first thing is you have studied well. Okay, you have studied well. Even if you refuse that, I will say that you have studied well, and you know that you have studied well in exam. Okay, in exam. Okay, you know that you have studied well in exam. Okay, the first thing is you have to avoid is tension. Okay, please avoid tension. Okay, because you are going to be within 500 ranks. Okay, whether it is less than 100, more than 100, that is the confusion now. Okay, because you have studied well. Okay, exam is testing reflexes, how fast you are able to identify and recollect from your remote memory. So your reflexes are good. Okay, your remote memory is very good. The only thing is required is smartness without tension. Okay, so as I say every time, you have two ways of solving the questions. Okay, one way is picking the option, another way is ruling out the option. Okay, so you should know in which question you have to pick the option, in which question you have to rule out the option. Okay, don't go by immediate jerk reflex. Okay, think for 3 seconds. Okay, then pick up the answer. Okay, and nowadays the exam has gone like to such a level that you have 4 parts. In one way or other, it is actually good. Okay, so whenever you do this part and you finished and you are into this part, don't think about the question what you did here. Okay, it is past tense. Okay, so your idea is only about the present tense. Okay, and one more thing is, if you guy is not going to get rank, then surely your neighbor will not get. Neighbor won't get. So you are going to get rank better than your neighbor. So for that, what is required? Confidence is required. Okay, don't do anything new or fancy in this next 8 days or 9 days. Okay, sleep well. Okay, so you can ask me, sir, exam is coming, you're telling me to sleep well. Okay, 6 hours to 7 hours you sleep, relax. Okay, so you relax. Okay, you close your eyes every day night before going to bed. Tell yourself, today I have cleared, studied lot of topics. Okay, and I have everything in my mind. I am going to do well in the NEET-PG exam, and I am going to be a topper in NEET-PG exam. Okay, please be with me in my confidence. So that is very, very important. Okay. So your confidence is one which is going to push you, okay, and motivate you for the next 10 days. Okay. So I know about my students, my kids, that they have prepared very nicely. Okay. And today is an example. Okay. So a lot of people were like feeling shy to answer in front of others. So I have getting lot of direct messages. That direct messages itself tell how well you have prepared. Okay. Your messages are excellent. You have prepared very nicely. Okay. Just refine it, find out your hard areas, just target your hard areas. If possible, if you require, you can anything. Okay. For 1 hour you can message me. Okay. And 1 hour discussion before exam, if you tell me some 10 areas to discuss, means I will discuss. I'm ready to do that. But you study well, you revise well. Okay. Don't think about any other things. Okay. March forward, win the race, and 23rd evening there will be party, and result day there will be party. Okay. So all the very best for your exams. Do well. Okay. You can message me. Okay. You can message me very well about anything. I will discuss with sir, and we can have a 1 hour session if anything specific is there. Okay. All the very best for your exams.